So the question here is shoulder impingement a myth or is shoulder impingement a real thing? And it's an interesting topic because on my social media pages, I get a lot of feedback about how shoulder impingement isn't real, how we can't tell patients that they have shoulder impingement, how we're not allowed to call it shoulder impingement. So, I don't understand that. In all honesty, if somebody has a pinching sensation or impingement or a sensation of impingement when they move or raise their arm, why can we not call it shoulder impingement? And again, some of the pushback that I get is, well, patients want a specific diagnosis. So I understand that. And, the patients are going to a physician, right? So if you go to a physician and you're looking for a diagnosis and you go in and instead of saying you have shoulder impingement, the physician says you have unspecified shoulder pain. So you go in looking for a specific diagnosis. You come out even more confused because now you have unspecified shoulder pain. So how is that even helpful? So I understand what people are saying when they say that we shouldn't say shoulder impingement because it's obviously a basket term, right? It's a very broad term. It's like anterior shoulder pain, but what is it causing the pain? So the term shoulder impingement doesn't bother me at all. I think it's a term, I still use that term occasionally. And I think it just makes sense. It's easier for me to explain to patients. However, I definitely will go more in depth and identify the structures that I believe are causing discomfort and explain that further to the patient. So, as far as being a myth, I do think shoulder impingement exists. I think it depends how you classify it or how you designate the term shoulder impingement. But if you have bad posture and you raise your arm as high as you can, and you have pinching in the subacromial space, that to me is shoulder impingement. What we need to do as healthcare professionals, though, is to identify why you're feeling the sensation you're feeling, where it's coming from, and then fix that. And I think now the newer school of thought is, it should be impairment-based treatment versus diagnosis-based treatment. And I completely understand that, and I agree with it. I think everything we do right now is impairment-based treatment, but I think we need to be able to explain things to patients without confusing them. We have a society now where everyone Googles everything, and patients come in knowing a lot more than honestly I think they even should, because it just confuses and muddies the water. So I am okay with the term shoulder impingement, but this is what I think needs to be done, right? So I think as healthcare professionals, you need to be able to decipher and determine what actually is causing the symptoms. And again, around the shoulder, there are so many things that can cause impingement. On top of that, you also have two types of impingement. So we have primary impingement, which is in the subacromial space, and that's potentially a rotator cuff, like the supraspinatus, could be the bursa getting impinged, or the bicep tendon that runs up along that space. And then there's internal impingement, which is what we see in a lot of our overhead athletes or baseball players. And for internal impingement, that is essentially when the arm is in an abducted and externally rotated position and the ball or that humeral head moves forward in the socket, you can pinch the back of the rotator cuff on the glenoid or on the labrum, causing pain on the backside or posterior side of the shoulder. So there are different types of impingement, so you clearly need to be aware of that. But I think it really comes down to your evaluation of the patient. So you're going to evaluate the patient anyway. So number one for me is posture. So what is their posture like? Typically, their posture of most people is actually terrible. From the youth and our kids that we see today, just the rounded shoulder posture from playing video games or just constantly on the phones. To your, middle-aged, just desk job or employee where they're sitting at a computer all day, shoulders round forward. So a lot of our society, we live in this forward position. So that's why most people tend to be in that forward posture, but posture is a big problem. So if someone comes in and they have those anterior tipped or tilted, protracted shoulder blades, that actually will decrease the space that the rotator cuff and the other soft tissue have to move around in the shoulder. So that subacromial space is decreasing, and that can lead to earlier pinching or irritation or whatever you want to call it, impingement perhaps, in the shoulder. So posture is always number one for me. After posture, and I tell the patients if posture doesn't change, then these symptoms may not go away. So that's always number one, and I'll explain that to them. Number two, I'll look at the shoulder blades again, just from a winging perspective. So, do they have medial border winging, inferior border winging? Typically, with really rounded shoulders, you might see some inferior border winging. So, what does that look like? And then going down a level to the thoracic spine. So how does the spine move? Obviously, the shoulder blades sit on top of the thoracic spine. So what does the movement, the flexion, extension, and rotation of the thoracic spine look like? And then even go up one level where we're looking cervical. If you want to just simply do a chin to chest, cervical extension, rotation exam to see if there are limitations from the cervical spine. Then I'll move on to some joint mobility. So I will assess joint mobility, passive range of motion, active range of motion, and then strength, looking for any kind of impairments around the shoulder that might be leading to some of the irritation of the structures that are coming up under the subacromial space. Lastly, I'll do palpation and special tests. I'll save that for last. In palpation and subacromial impingement, what I typically will in the back of my mind, I'm thinking bicep tendon supraspinatus. So I'll palpate up along the proximal bicep tendon, right along the lateral side and around the supraspinatus. And I'll see if there's any tenderness there. You'd be surprised. You can actually feel, especially on some people that don't have developed deltoids, you can feel that subacromial space and almost like a little pocket of inflammation. And they'll tell you, like, that is my pain. Special tests, I mean, I sort of take with a grain of salt. Obviously, if you do your impingement test and you take someone's shoulder and flex it as far as you can overhead, at some point it's going to hurt. I mean, if I do that to my shoulders, which I deem are moderately healthy, that hurts too. And then same thing, coming across body and forcing into internal rotation. We're essentially trying to scour the rotator cuff under the humeral head, or I'm sorry, under the acromion. So, I'll take that with a grain of salt. Speeds test to rule out biceps, O'Brien's compression, maybe to rule in or out labrum. So I will do a small cluster of tests, but I don't think that's my determining factor. What I typically will do is I will have them supine, so they're on their back, and I'll have them just raise their arm back as far as they can without any assistance. And when they go back, I'll just have them stop when they start to feel pain. Then what I will do is I will actually take my hands and put it under their shoulder blade. So I will give their shoulder blade some inferior medial pressure. So I will try and push. So say it's a right shoulder pain that they're having, a right shoulder impingement, if that's where we're going here. I'll have my hands under their right scapula and I'll be pushing it towards their left hip. And then I'm going to have them actually flex their shoulder again, and my purpose is to get more retraction and posterior tipping of the scapula, which in my mind is going to open up the subacromial space a little bit or give them a little more. Then I'll ask them to move their shoulder again, and if they have less pain and they can move further than they did previously, then to me that's positive for shoulder impingement. And then there's treatment. So treatment-wise, obviously we're going to treat the impairments. And yeah, I mean, I guess that goes back to your impairment-based treatment, which is what we were doing all along, just with the term shoulder impingement, I guess. But then we'll treat the impairments. So joint mobilizations, cervical spine, thoracic spine mobility or stability, whatever they need, scapular neuromuscular reeducation. A lot of patients sometimes can't even just retract their scapula, something very simple. If they're in that protracted position for too long, sometimes it causes a little bit of inhibition of those scap retractors. So really work on some neuromuscular reeducation of the scap muscles, a little bit of rotator cuff co-activation just for some force coupling around the shoulder. And then we'll start to advance, scapulohumeral strengthening. And that really, for me, has helped treatment-wise for whatever you want to call this term, whether it's anterior shoulder pain, shoulder impingement, non-specific shoulder pain, which actually drives me crazy because if I went and paid a copay to see a doctor, they told me I've got non-specific shoulder pain. I mean, I needed a little more than that. So treatment-wise, that's essentially what I'll do. I'll look for the impairments. Obviously, if they saw a doctor already, they might have x-rays. Shape of the acromion might matter. So if you've got a hooked acromion, then you clearly have less subacromial space, which might lead to earlier compression of the soft tissue structures, whether it's the bicep tendon, the supraspinatus, the bursa. versus the flat acromion. So there are some of those structures. They might have an MRI. But if they're not better for me, I give it about 6 weeks max. So in 6 weeks, you don't have to be 100% better. But in 6 weeks, if you're not trending positive and there's no change in your symptoms, then I would refer, if they haven't seen a physician already, then I would refer back to a physician to see if they can get a further workup, maybe MRI, to see if there's something else happening in there. So I guess it's a long-winded answer. Shoulder impingement to me is not a myth. I think it's something that exists, but yeah, it's a broad term. So we do need to find the specific structures, but I don't have any problem telling someone they have shoulder impingement as long as they understand what is happening and what they need to do to fix that problem. So please like, subscribe to this channel, share with anybody. Feel free to look at some of my previous posts and comment any future questions you might have that you want answered. Thanks.